Yeah, good afternoon, everybody. And on behalf of the Chhattisgarh Ophthalmological Society, I welcome all of you for this special session which the AIOS Scientific Committee has been kind enough to grant us. And I hope that the audience is going to have uh, an interactive session which is going to benefit them in their practice. As soon as we have the laptop set up, we will be starting. Madariya sir. Right.
Yeah, so the first speaker is our Honorable Dr. L.C. Madharia. His topic is preoperative inattentiveness, a catastrophe. Each talk is of 6 minutes. So I request the timer to be adjusted that way.
ये कहाँ से आगे कैसे बढ़ेगा? नेक्स्ट कौन सा है? ये नेक्स्ट है और बेक ये था. Can you start?
कहाँ गया?
Respected chairpersons sitting in the dais and respected audience of the dais. First of all, I thanks APAO Scientific Committee and our Chhattisgarh Ophthalmological Society chairperson Dr. Lalwani sir. They have organized this beautiful symposium on, as we all know, we all are the 60-70%, we are all the cataract surgeon. And for the better results, we need a better pre-operative evaluation, intraoperative, operative and post-operative. As lot of mistake has been created during the pre-operative phase, in which there we faces a catastrophe. So this is the topic on which given to me is the preoperative inattentive catastrophe. As we all know, if a good surgery is done, then the vision is 6/6. So the patient goes with the smiling face and the surgeon also having the smiling face. But if something happens to be wrong, then it results into that catastrophe. That is a very bad, which never a surgeon wants. That is the endophthalmitis. The adequate measures should be taken before any ocular surgery. The aim is to minimize the risk of the contamination and the infections. Preoperative preparations, the baseline investigations, as we know, the blood pressure and the blood sugar, the maintenance of the hygiene, the pre-existing disease, which may be diabetic, hypertension, heart disease, asthma, dental caries, and neurological problems. And there must be clean OT and the aseptic precautions. The baseline investigations, the pre-existing disease, if there is associated diabetic hypertension disease and all allergic condition, these has to be well controlled, and preferably the medical clearance should be taken from the MD medicine if these patients are having these diseases. Then the random blood sugar should be preferably less than the 200 milligram of medical check-up and clearance, as we have already discussed. Then in case of the children, the routine and microscopic urine checkup and the culture should be done. And in case of the orbital surgery, the blood sugar, blood grouping and the BT-CT has to be done preoperatively. Then the topical antibiotic, the broad spectrum antibiotics 4 times, preferably 3 days before, to decrease the bacterial flora, and preoperatively tropicamide every 10 minutes before surgery 3 to 4 times. Then the phenylephrine should be added in case of hypertensive and the cardiac patients. Then this slit lamp examination, this is very important before the surgery to see the lid and the adnexa. The preoperative, the regurgitation test, it should be done 1 day before, and it should not be done on the same day. And if there is infection in the sac, so either the DCR or the DCT should be done, and minimum 2 weeks after these two surgery, the cataract operation can be done. The A scan 1 day prior preferably should be done, and one should avoid the contact biometry on the day of the surgery. Intraocular preoperative 1 day before surgery, if should be done, and it should be within normal range. Then in the operation theatre attire, patient should be well covered. The cap, mask, the OT cloths, and the foot shoes. These are things should be there to prevent the infections. Then marking and the cleaning of the surgical area. The right patient, this is very important. The right patient, right eye, and the patient name and the hospital ID, there should be badge to prevent the interchangeable of the patients. Many times we read in the paper that the right eye was to be operated and the left eye was unfortunately operated. So sometimes this blunder happens, and in a big medical legal, not only the medical legal problem, but it is a very bad thing for the surgeon and for the patients also. The pre-operative cleaning with the 10% pyridine in the ward should be done, and the identification marks should be there in the forehead, the eye which has to be operated. This we all used to do in the earlier cases also, when we used to do a large camp. Then the shifting of the patient in the OT along with the badges. Then the surgical preparation, we should clean with the 5% pyridine for 3 minutes. And in the high risk patient of the HIV, HBS, and all these patients requires special attention, and ART should be continue. And then conclusion, importance of knowing various steps in pre-operative period to ensure strict asepsis and prevention of infection, to ensure early and good visual recovery. This will prevent post-operative catastrophe which result in endophthalmitis. Thank you very much.
Thank you very much, sir. If it's okay with everyone, we will be taking the questions at the end of this session. So I invite the next speaker. It's Dr. Ankur Srivastava, who will be presenting his talk on biometry, surprises or blunders.
So good afternoon, everyone. I am Dr. Ankur, Professor of Ophthalmology at AIIMS Raipur. And we all in our dreams have target emetropia. We all are, sir has said, we all are primarily cataract surgeons and running for emetropia. And the essential backbone of cataract surgery is a good biometry. That is a proper IL power calculation. So what we are doing, are we doing biometries giving us surprises, or are we doing blunders and surprising ourselves? So that is what is important required today. I have nothing to disclose financially in this presentation. So what it essentially means is it measuring the various dimension of eye's component, its interrelationship, and then using this data to determine the ideal intraocular lens power. It essentially consists of two parameters, that is keratometry and axial length measurements. So keratometer, we have seen different generations, like when we are postgraduates, we have seen this Bosch & Lomb manual keratometer. We started with this, and now it has moved on to automated keratometer and various topography techniques. So these are the sources in keratometry errors. Most commonly it is the unfocused eye, but nowadays with autokeratometers, these many things have been overcome. What is important is that when to repeat the keratometry. So if the corneal curvature, that is the readings when it comes more than 47 diopters or less than 40 diopter, or there is difference in cylinder more than 1 diopter between the eyes, it's time to repeat your keratometry values. Then the second essential component is the axial length measurement. We have seen various advances in it, started from ultrasound, direct application and immersion, moving on to optical, and finally swab source and intraoperative aberrometry. So an axial length is around 20 to 24 mm. We have been taught that around 1 mm difference in axial length measurement, this results in around 3 diopter change in IL power. So it has a huge impact. Again, the measurement has to be repeated if the difference in axial length in both the eyes is 0.3 mm, or if it is on the myopic side or hypermetropic side, less than 22 mm or more than 26 mm, then yes, repeat the axial length measurements. Now, appellation tonometry more or less has been obsolete, so but still in some far-flung areas, optical biometer is still a dream, and we would advise them to go for immersion. If not, if you have only appellation tonometer, then these are the some tips for accurate axial length measurement by appellation tonometry. Now, these are certain special scenario when the patient comes with, you have to be careful with your scan and use special methods like inadequate fixation, posterior staphyloma, extremes of the axial length like high myopia or high hypermetropia, macular lesions, vitreous pathologies, dense cataracts, silicon filled eyes, and nowadays more and more patients coming post-refractive surgery. So these are the things you have to be careful when you are doing A scans. Never to say there are a lot of advantages of optical biometer, more or less it is an automated system. What we find most importantly is the reproducibility. Every time you repeat the readings and you are getting the same and same readings. So reproducibility is very important in your machine. Even in routine patient, reproduce, if not, calibrate. So these are the different generations of IOL power calculation formula, the newer ones like Barrett, Olson, Hill, RBF, and Kane. And these are according to the variables which are used, like 2 variables, 5 variables, 7 variables. And more importantly, nowadays, artificial intelligence has come into play. Hill RBF is based on artificial intelligence based formula. So these are the recommendations for the, depending upon the axial length. Different people have different choices. What I commonly use is less than 22 mm, go for Hoffer Q. Otherwise, Barrett Universal 2 is a universal formula which is truly named so. So in other, you can rely on Barrett Universal 2. A word about A constant that is imprinted on the IOL, and you have to be cautious with this because it's different for optical and ultrasound. Optimize this A constant and you can personalize it for yourself. If you don't want to do that tedious process, go ahead to the ULIV website, you can get that optimized A constant and then use, and believe me, it makes a difference. So these are some of the causes for inaccurate biometry. These are measurement errors, calculation error, transcription errors, and patient factors like dry eyes and irregularities. So how to minimize the biometry? Because many times we leave biometry to our optometrist. So use a better biometry technology, better repeat it and double check it. Now these are some case scenarios which I like to show. In this, the axial length is around 30 mm difference, 0.30 mm difference. It's not much of a difference, and you can see the findings of both eyes, the keratometry, axial length, they correlates, and hence the IOL power correlates. If you go at this eye scan, you can see a huge difference in the IOL power, and when we go back, it is this. That is the axial length, which is much of a difference, and hence repeat biometry, and especially if you have an excess, repeat it with a different instrument. Again, in this patient, you can see the IOL power is coming in 5.5 diopter. If you go for the axial length is not very difficult axial length. So what is causing so much difference in IOL power? That is the keratometry values. So look for this and go in a better way. Repeat the findings, that is what. Now this is another patient. In this, it is extremely long eye. Axial length 31.32 in the left eye and 32.36 in the right eye, and hence the IOL power is coming in -3. So what I would suggest finally is, if you are going for anything extreme, then repeat and repeat before actually implanting and going for an IOL exchange. That really helps you in difficult case scenarios. Thank you all for your kind attention.
So I invite Dr. Saurav Luthra for his next talk, Rex's Follies.
Thank you. So let's straight away start this. We all know CCC plays a very important role in our newer generation cataract surgeries. Where I was trained, I was told 3 steps in cataract surgeries are very important: a good rexis, a good incision, a good rexis, and a good hydro. That's what makes your life convenient in your surgery. So yes, it's often underestimated until it goes wrong. A good rexis forgives many sins, but a bad one demands panache. Ideally, it should be a 5.5 mm rexis. You can alter it depending on the size and shape. Should overlap the optic by 360 degrees. It should allow easy nucleus manipulation, stable IOL placement, least or reduced PCO risk, and acts as the foundation of the surgery. We've started from here, we've reached here with the newer machines, of course. So as I said, a smaller rexis, anything less than 4.5 millimeter, increases the risk of phimosis. A larger rexis more than 6 mm, potential for IOL decentration. an eccentric rhexis, which can be a good sized but an off-center rhexis disturbs you, especially when you're planning a premium IOL, especially a trifocals or EDOFs. Runway rhexis, tears extend uncontrollably to the periphery, a radial tear which can lead to a capsular rupture, and an incomplete rhexis, ends probably not joined properly, has a risk of extension, especially at the time of hydro. Smaller exercises, how does, how it can really happen? Fear of extension. You start really close to the center, inadequate visualization at times, and early beginners, of course, we've all made that mistake. The complications, difficult nuclear rotation and emulsification, risk of capsular contraction syndrome. Management wise, you have to have all these newer tools like the micro scissors and the forceps, atratas, and the micro the newer forceps which goes through the side port, so that you can really help them extend well. Stretching with the hooks, if at all it is really advanced phimosis. Larger overconfidence, keeps on going farther. Poor anterior chamber maintenance at times, and an excessive flap pull. IOL, the problems associated are decentration and an haptic exposure, which can at times lead to negative dysphotopsias. Pearls marking on the cornea with a 5.5 millimeter marker before the planned rhexis, and a better control with microforceps with cystitome alone. Eccentric, a good heart-shaped rhexis, but it can cause IOL tilt and optic edge glare, a cosmetic dissatisfaction in the premium IOLs. How to fix them? Try and the visual clue can be of the first Purkinje image, the corneal reflex, use of the marker as we discussed before, and there is no harm staining the delineated capsule edge. Runaway rhexis, we are all scared of these rhexises at times when they start going in this extreme. High intralenticular pressure, sudden chamber fluctuations, signs of sudden uncontrolled extension towards the periphery. We've all had this in our practice. I'm sure Argentinian flag sign occurs in intumescent white cataracts, whatever best you do, maybe a IV mannitol before or whatsoever, but it can still happen in the best of the hands. Prevention, decompression of intralenticular fluid. I'll be showing a small video later on that. Staining, I tend to stain all my capsules here, especially in cases like this. Initiating rhexis with paracentral area, and regrasping rhexis edge, quickly converting to can opener if at all needed. Most complicated and the difficult ones are the pediatric, and the complicated cases are the highly elastic anterior capsule. These are the biggest challenge in the pediatric cases. Tendency to run off is much more higher. Fugoplasma blade used at certain centers, it tends to give you a good sharp edged rhexis. High speed vitrector for vitrectorhexis, and good use of OVDs with higher viscosities like the Helon GV or 5. Tips: shift to a higher magnification, firm chamber with cohesives, viscoelastic, and a two-stage technique can be helpful. These IOL demands a good rhexis, so these are very sensitive towards centration. So the Foley's impact, decrease efficacy of multifocal zones, astigmatic correcting, offset in toric IOLs can happen. Visual aid, split image of a centered versus decentered IOL, especially in the other eye if it is something like that. So tip here would be a central rhexis over visual, fixing the center over the visual axis, the first Purkinje reflex instead of the pupillary center. Always stain the capsule, use rhexis markers here. Good micro rhexiv forceps and atratas, of course, allows better control at times. Then the cystitome, maintains stable chamber to avoid runoff. A two-stage rhexis, as we discussed, can or rather be helpful in white and pediatric cataracts. These are the available tools. I mean, certainly femto is one of the best available options as of now, but of course, so this is something what we've really discussed. The tips again, milking technique is very helpful in the white cataracts. Staining, of course, is required. Spiral rhexis in rescuing the radial tear. Scissors and fibrotic capsules. Scissors for the fibrotic capsules. Just a small video how the little maneuver comes into place. I'm running a little faster here. This is 4 times the speed, don't worry. This is how I don't operate that fast. Little demilking is done here. You pull it and pull it right opposite. I'll be showing it in a little slow motion here. And it comes back to you. So this really helps. It's a good maneuver. Practiced, it will certainly come with practice. And where you feel that you need to go on to a higher magnification, you go, and so that you have a good centered, good edged rhexis. One more smaller video. This was again a phacomorphic glaucoma case with a very shallow AC. Small side port entry, careful so that I don't puncture here. Staining, of course, helps. form the AC, enter slowly. Here I am somehow more comfortable using a cystitome. So I've just picked up the flap. I go in with the 27 gauge, nothing comes out. Go with the 23 gauge, just finishing. Now you can see those fluffy little cortex coming out. You have to be very careful while demilking these cortex, because here also there are chances of, the Argentinian flag size are very high. I will just show one more thing. In cases like this, once you finish the rexis, I've used everything here, my atratas, my micro assist forceps, and I thought it is comfortable here. Again, it is so fibrotic that I have to go very slow here. I was losing my patience, but again, God was kind. And in these particular patients, before going with the phaco probe, you take a IA probe in, again do the demilking more comfortably so that you have the space for the nucleus to be rotated. Final thoughts: it can make or break your cataract surgery. Even experienced surgeons encounter rexis surprises. It is forgivable only if we learn from them, and the key is anticipation, skill and control. To summarize: assess before you start lens type, chamber depth, respect the capsule, it's fragile and unforgiving, use the right tool at the right time, always be ready with the plan B. A good rexis sets you free, a poor one changes the rest of your surgery. Thank you.
I invite Dr. Anand Saxena sir as next speaker. Topic: overcoming nucleus management. Saxena sir.
Thank you, sir. To prevent mismanagement, the best thing to prevent the odd situations, and there are few factors one should understand that what can be the factors behind this is the machine related and most important soft nucleus and hard nucleus. Machine related problems are now less as the very good machines are available with good fluidics. Of course, the old phaco tips are definitely giving the problem in occlusion, the nucleus piece. Blockage in the circulation is often do occur when we reuse the tubings multiple times. It's better to use the disposable tubing and cassettes. You can see very well on the right side, the tips are new tips are very good edges, while on the left side the edges are ragged. If you see the lumen of the old tips, there are a lot of deposits and irregular, which give definitely the problem in the suction and occlusion of the nucleus piece. We have to use the cassettes, and you might have noted in so many wrappers of the tips that it is for the single use. It's written in the top of the packet of the tips. Sorry. This is for the soft nucleus. If you can achieve, if you achieve the multiple rings like this, multiple golden rings, then everything becomes very easy. Sorry. Can I help someone? ये दूसरा अब सही आया शायद. Yeah, in the hard nucleus, one should be very careful for the posterior plate. It is my first concern that it should be properly, the plate should be braked. We should be very patient, no any jerky movement, rotate preferably bimanually, and take care in the separation of the posterior plate. It's a very hard nucleus. We have to take all the care for the posterior capsule. Don't go very deep. Don't press it posteriorly, just side by side. You have to keep full patience, and you can achieve a good separation. Also in the direct chopping, you can have the problem that you are unable to crack the posterior plate, and while doing the cracking it, you may create lot of unwanted problems. You have made so many pits in the both half of the nucleus. I am trying to rotate using the multiple side to create a separation between both the nucleus. There is very thick posterior plate. See, this is another pit I have made, and really it is very difficult to remove this large nucleus from the capsular bag. So what to do? I usually clean the anterior chamber, remove the epinucleus, and re-inject the high whisker, remove half of the quadrant, pull it to the posteriorly, and do the vertical chop. So a small piece of the vertical chop debulge the nucleus and make the space for further phaco. See how to crack properly. So this is the hard nucleus. Have a good patience, no pressure on the posterior side. Our goal to remove every strand of the nucleus separate. See, there are fine strands. In the hard nucleus, this is the last piece of the big quadrant. So here I take the two main things. I have to prevent the posterior capsule as well as the corneal endothelium. So I inject the heavy viscous in the bag also to push the posterior capsule posteriorly and anterior to nucleus also. So by this way we can save the cornea as well as the posterior capsule also. This is the case where you see this is very ragged, no smooth surface to occlude it. So I pull it mechanically in the center and make it upside down. The posterior area is the very smooth and can create a good emulsification.
Sir,
In
could
the
you
soft
summarize,
nucleus,
sir?
if you achieve this kind of situation, then the things become very easy. Here is a soft nucleus where what we plan to remove the pieces of the soft nucleus by the epinucleus mode, bring it to in the center and then emulsify it.
Sir, can we speed up the video or summarize because we're running short of time?
Sure.
Thanks. Thank you.
Here is a big saucerization in the center. I have to expel it with the visco expression is done. We remove it and bring it to the center. So it can be emulsified fast. It is an old technique of the flip chop where we just hold it from the corner of the nucleus, bring it in the center and then chop it. You see, like this, we can do the complete flip and chop technique.
Is the next speaker ready?
So, this is the take-home message. Good pre-op assessment. One should keep all the problems in mind to master all the ways and tricks to manage the situation, and experience will teach you how to manage the overcoming the nucleus management. Thank you.
Our next speaker
Sorry
is
for
Dr. Santosh.
taking much time.
Okay. Yeah, please. नहीं, आप बोलिए.
Our next speaker is Dr. Santosh Patel. Topic: nucleus drop, mishandling the storm.
Harshvardhan.
Good afternoon, respected dignitaries on the dais and after the dais. Today's my presentation on the nucleus drop management, no financial interest. Given the variety of the pathology presented by the human eyes, even the best surgeon have some complications. Despite the application of the vigilant manure, PCR still occurs at the rate of between 0.45% to 14.7% depends on the experience. Retained lens fragment is estimated 0.3% to 1.1%. So aim up to that presentation to minimize the risk of complication and to manage the optimally complications that do occur during the cataract surgery. Conditions that put patient at risk for the dropped nucleus are posterior capsule could get injured by the anterior intravitreal injections. This is most commonly performed procedure in the ophthalmology. Posterior polar cataract have a high incidence of posterior capsular rent formation, rupturing the posterior capsule during the chopping and cracking, and most commonly hydro-rupture of the posterior capsule during the hydrodissection with pupil snap sign. There are two stages of the dropped nucleus. Dropping nucleus and dropped nucleus recognizes the tilting nucleus away from the anatomical position to slide backward into the vitreous cavity. If this dropping is recognized, you can manage with the 23 or 5G needle can be inserted via the pars plana, aiming to go behind the nucleus and lens elevated to forward into the anterior chamber and can be removed by the vectis. And care has to be taken for the vitreous traction. If the nucleus has already dropped to the retina, a vitreoretinal surgeon is required. Management of the dropped nucleus. It is important to preserve as much as of anterior capsule as possible so you can still implant IOL over the anterior capsule. Focuses on the cleaning of residual cortical matter and doing the best anterior vitrectomy possible. In a stressed state of mind, do not chase the nucleus, do not try to retrieve it, and do not deny that the complication has occurred. So if the surgeon has not feel comfortable handling the cortical matter, better to stop. For the drop nucleus without using the fragmentome, perform the vitrectomy with the 23G vitrectomy system, and after PVD induction, use PFCL for the protection of the posterior pole to aspirate the nucleus by using a 23G vitrectome and implant the IOL depends on the situation and remove the PFCL. So advantage of this technique, we can prevent the widening of the sclerotomy and minimize the risk of the retinal injury by preventing the intravitreal maneuver and decreasing the surgical time. But the limitation is hard cataract. We cannot remove the hard cataract with the vitrectome. And for the hard cataract, we can elevate the nucleus with the PFCL and remove from the anterior chamber. So with hard nucleus, you want to treat with inside the vitreous cavity. Then you need a fragmentome. After complete vitreous removal and all the tractions, do PVD so that you can use PFCL. And after that, enlarge the sclerotomy with the MVR blade for the fragmentome. And then use the fragmentome for the removal of the hard nucleus. So after completion of the vitrectomy, you can plan your IOL depends on the anterior capsule status. Same for the IOL drop also. So same vitrectomy and remove all the tractions and pick up the IOL with the forceps and remove from the anterior wound. So after after removal of this lens, you can proper clean up anterior cortex. Then you can plan retrofixed IOL as a IOL of choice without a capsular support, and you can close with the suture. So indication for the types of IOL, lack of the capsular support or lens replacement or exchange or dislocated lens, you need a scleral fixated IOL or the retrofixated IOL. But you have a good CCC, you can place a 3-piece IOL or sulcoflex IOL. So these are the photographs of the retrofixed IOLs. For the scleral fixation, you can fix a 4-point fixation or single 1-point fixation. Here you can do 1-point fixation with without any knot and without any scleral fab. So you just plan IOL scleral fixed IOL as a normal routine and suturing the eyelets, and after that just give a 3 to 4 rows of the suture both the end without giving a knot. So for proper equal and proper tension, and this 4 per section is good for the SFR. Here you can see the post-op photographs of the 3 to 4 loops of the suture without a knot. So outcome, primary cause of the visual impairment in nucleus drop, so start macular edema, pre-existing ocular disease, corneal edema, retinal detachment, and the epiretinal membranes. And significant predictor of better visual acuity is better presenting visual acuity, presence of intraocular lens, no suprachoroidal, no choroidal, no RD, no CMA, no additional surgery. So there is no significant association with final visual outcome, and IOP outcome depends on the timing of the surgery, whether within a week or more than 12 weeks. For counseling, one of the most important thing for managing this patient to communicate with the patient. First in the operating room, second in the after the surgery, and third communicate with the patient till second surgery with the retina surgeon. So as a take-home message, early detection of the dropping nucleus you can prevent for the further surgery from the retina. In a state of mind, do not chase the nucleus and do not try to retrieve it. The best timing for the vitrectomy is possible, probably the same sitting as the cataract surgery, as this negates the need and cause for the repeat surgery. And timely and wisely management of the situation is vital for both patient and surgeons. Thank you all.
Next, I invite Dr. Harshvardhan Gupta for his talk on premium IOL, expect the unexpected.
Thank you, Dr. Soma. This was like the trick question. This was a sort of trick topic. I did not know what to expect from this talk, so tried to have made something out of it. So, what are the things that we can have which are with the premium IOLs where we can land up in trouble? So, premium IOLs are premium lifestyle lenses. They correct a wider range of refractive errors than standard IOLs, correct presbyopia, then potentially eliminate or reduce the need for glasses at all distances. Multifocal IOLs have different zones for clear vision at different distances. Accommodative IOLs mimic eye's natural focusing ability, and toric IOLs, of course, correct astigmatism. The special considerations are that they are more expensive, not always covered by insurance, and we have to tailor individual needs with specific models. Thorough counseling of patients is needed. The surgical issues are intraoperative, like PC rent and iris defects, and postoperative are residual refractive error, IOL decentration, corneal edema, dysphotopsias, CME, and early PCO. In the back placement, if in the back placement is not possible because of PC rent and if capsular integrity is compromised, instead we can do a primary or reverse optic capture. Iris defects may present as trial illumination defects, iris atrophy, and or pigmented dispersion. If large, pupilloplasty to avoid glare and dysphotopsia. And to prevent it, we have, of course, to do adequate pre-op planning, intracameral adrenaline for small pupil, and long intracorneal incisions beyond the iris root, and low fluidics. Refractive surprises occur in 12 to 15% of the cases because of long or short axial length, previous refractive surgery, irregular astigmatism, keratoconus, corneal scarring or dystrophy, mature cataracts, OSD, and long-term contactless wearers. Also because of anisometropia, dominant switch, post-op high astigmatism, and of course, unmet expectations. Glares and halos, especially with multifocal EDOF lenses, are the most difficult to tackle from the patient satisfaction point of view, and there are other night vision problems also. If there is inherent zonal weakness or traumatic and others because of improper implantation, then we can prevent it with capsular tension ring. And there may be elevated IOP because of retained viscoelastic, which is most common on PO day 1. Patient may be steroid responder, which comes with high IOP 3 to 4 weeks after surgery, or inflammation. Anti-glaucoma drugs are sufficient in most cases on a temporary basis, but of course we can have a case of malignant glaucoma where surgery or atropine may be required, as the case may be, as the case responds. Iris defect with pigment, IOL redialing, IOL haptic on sulcus, a peripheral iridectomy. CME patients with diabetes and macular pathology are at higher risk. If they do not resolve within 8 weeks, a subtenon intravitreal Kenacort or Ozurdex may give us relief. Of course, to prevent it, pre and post-op NSAIDs, they definitely decrease the incidence of post-op CME. PCO ND yak laser cap is safe. A low energy small yak capsulotomy sometimes is also useful for positive dysphotopsias. So to manage expectations and unexpected outcomes, preoperative counseling, realistic expectations, good post-op care, promptly address the visual issues, and I will exchange if required, patient education, and still the refractive surprise enhancement by a laser procedure can be done, and which we have done also on occasions. Thank you so much for your kind attention. Thank you.
We next have Dr. Samrat Chatterjee, and he will be speaking on tough cornea, tougher cataract. So it's on this side, and thank you, sir, for finishing well ahead of time. Yes, you made it. Thank you. Thank you.
So, is there a pointer? So, thank you to the Chairman Scientific Committee CSOS and also AIOS for organizing this talk. So, the theme is, surgical insights from mistakes. So, some carry home points from mistakes that we make. To err is human, but it is also human to learn from the mistakes. So, what had happened was that a 39-year-old gentleman had undergone LASIK way back, and subsequently he developed cataract. And then he was operated for cataract elsewhere, and a 12 diopter acrylic IOL was implanted. However, a month after the surgery, there was a pointer है नहीं है तो please दीजिए. So he landed up with a +5 diopter refraction. So this was the 5 diopter refraction. And when we again refracted him, it was still 5 diopter. And when we repeated his axial biometry for the A scan using the IOL master, at that time we had 500, and also the ASCRS platform, we saw that the average lens was 12.90, and the maximum, because it gives us the ASCRS calculator gives us the minimum, average, and maximum. The maximum was 16.46, but the minimum average was 12.90. We normally use the average, and the patient had undergone 13 diopters, so it didn't add up. So we didn't know exactly why this patient had a +5 diopter refractive error, and the usual reasons that is there is that it can be because of overestimation of corneal power. That is the first mistake that usually happens if we don't use the IOL corrected formula, because of issues related to the anterior and posterior curvature of the cornea. They get altered after laser vision correction. It is because most of the keratometers and the topographers does not measure the center of the cornea. Also, there is the errors with the effective lens position, which the newer formulas incorporate, because the anterior and posterior curvature ratio is altered. Neither can you use the refractive index of 1.3375 for calculation of the corneal power, and also the effective lens power is also not very correct. So in myopia, there is an overestimation of K, and so usually the result is a postoperative hypermetropia, and the opposite happens for hypermetropia. So there are various IOL formulae for doing the IOL power calculation in cases of laser vision correction, and because you can see that there are so many number of formulae and so many techniques, we know that it is still, there is a lot of things that we don't know about it. There's a lot of variability, but normally what we currently use is the ASCRS IOL calculator that uses 3 or 4 formulae to come to the the accurate power. So what had happened to our patient? Because the ASCRS IOL power calculator did not actually give us the true picture. So we are getting 13 diopter, implantation was 12 diopter, but 5 diopter was there. So the clue was, again, when we went back and did a topography and we examined the topography pattern. You can see on the right hand side that the zone of ablation is well centered, whereas in the left eye that was operated, the zone of ablation is decentered. And this decentration has made the all the modern formulae erroneous, because the model formulae was overcompensating for the cornea, but in this eye, the light rays or the OCT rays were actually going part from the normal cornea, part from the ablated cornea and the transitional zones. So that had led to the error. And what was the solution? Because the AIOS power calculators was not giving us the correct solution, so we did the phakic refraction method, where we explanted the IOL and we then did a manual refraction, took the spherical equivalent and put it into all these formulas that you see out here. So these are some of the phakic refraction formula that you have, and then based on that we calculated it and we got a power of around 17.86. So we implanted a 18 diopter monofocal lens, and 1 month we got a cylinder of -1 diopter cylinder, and there was no spherical spherical error. So it was correct, and the explanted IOL we had sent back to the manufacturers, and they said it was 12 diopters, so it was not an error in the IOL power calculation. So was it a fluke? It was not a fluke, because we used the same ASCRS IOL power calculator doing the IOL power calculation in the other eye, where the zone was well centered. And you can see that again we landed up with a -1 diopter cylinder after 1 month, and there was no spherical equivalent. So is it only for this? It is not only for this. So following this case, we also operated on 3 other patients. One had a corneal scar that made the IOL power calculation very difficult. In another patient, there was microcornea and coloboma, and the other patient had very significant flattening after RK, in which the ASCRS power calculator was not accepting the corneal values. And in all those things, we implanted it. The error that we had out here was that we presumed that the error like we overcorrected the lens IOL power in the left eye. So these are the solutions that are available. Formula you can actually look up in the net. So if you have a patient with LASIK or PRK, any laser vision correction, rule out if there is decentration. If there is decentration, then probably the existing methods are not correct and can land up with refractive surprises. Thank you.
Dilip Lalwani, trap or trouble? Heco trap or trouble?
Good afternoon, and thanks AIOS for organizing this state symposium. And your phaco trap should not become a phaco trouble. So here is a cataract and glaucoma many times coexist together, and no general consensus on surgical management, and surgeons should decide patient-centric best approach depend upon severity of glaucoma and visual compromise from cataract. So let us take a scenario 1. There is a mild glaucoma with very elderly patient with multiple comorbidity, but controlled with only one anti-glaucoma. So you can do phaco alone in this case, and it will, but negative aspect, it may create significant IOP spikes because of retained cortex or steroid dysfunctional trabecular meshwork, and this IOP spikes sustain for 2 to 4 months. So cataract surgery alone is a bad option in treating uncontrolled primary open-angle glaucoma, but may be treatment option in acute congestive glaucoma. So let us take second scenario, where this is uncontrolled glaucoma despite maximum therapy and SLT with minimal cataract. So we can go for trabeculectomy only, and this reduces the post-op need for IOP lowering therapy, and this may improve the vision and quality of life enough to delay cataract surgery. And cataract surgery can be taken later, 2-stage procedure. So where is the combined surgery indication? All this advanced cataract with inadequate control with therapy, adequate control with severe drug-induced side effect, or with advanced glaucomatous optic neuropathy, or uncontrolled glaucoma with urgent need to restore vision, and whenever there is a 2 surgery are not feasible in the patient's best interest. So let us take phaco trap. Pros are, it is a convenient, reduce the costs, reduce the risk for multiple stresses, anesthesia, and it avoid potential IOP spikes. But Negative aspect, it may create more complication, challenging in a small pupil, synechitis or zonular stress areas, and induce inflammation in one side surgery. And after all, it is less effective IOP control in advanced glaucoma. So proper evaluation is the key before doing right phacotrap, like how many AGMs are patients on, visual acuity, IOP, gonioscopy. You have to all take care, and mistakes can happen from the conjunctival button holing, and videos are not running. So scleral button holing, very anterior chamber entry, trabeculotomy before phaco you should not do. Posterior sclerostomy, loose scleral suturing. So it is a single side phacotrap. It saves time, no need to change the position, but induce more inflammation and may spill mitomycin C in an antechamber. This video is also not running. Okay, so single side phacotrap, you can go from the single port where you do a cataract, then after that trabeculotomy done, but you should resort for the minimal cataract or early cataract. Dual site, you can give improved exposure, and it is best in a dual set, narrow interpalpebral aperture, less inflammation, and it may recover rapidly, and it is an enhanced bleb survival. You can see here over the bleb, you can enter from the clear cornea also. This is the dual site also. If you are two surgeon, you can go for temporal cataract, then do from anterior phacotrap. This is also not working. Okay, so IOP control, both approaches have been shown to be effective in lowering eye intraocular pressure, and two-side surgery may have better post-op control and less need for adjunctive glaucoma medication. So here is you can take out the lessons. Before the phacotrap, maintain antechamber with the use of viscoelastic, use mannitol preoperatively, and it should be clear corneal antechamber entry. Never do trap before phaco, and never ever antechamber become shallow during procedure. Don't make ostium too posterior, it may induce bleeding, and scleral suture should be tight enough to prevent hypotony, and hypotony is worse than a high IOP. And do a titration before closure, and it should be watertight like you can see over the picture, and thank you all. Okay, time is over. You can see. आपका सर 2 मिनट बचा था. ओके, ठीक है सर. 1 मिनट. So here you can see over the flap, you can take clear corneal entry. This is a single site. Entry, but you should also do as a clear corneal entry, not more anterior, not more posterior. Otherwise, your iris become prolapse and you will be get troubled repeatedly iris prolapse. This is a single site. So it is a very mature cataract, so you can, but you can see over that saline is coming out and chamber is sometimes difficult to maintain in the hard cataract also. You can see the hard cataract here. This is a dual site, per same, no need to change the position. One has to change the position for the temporal clear corner. This is a side port entry. And after this, bus. Last. This is the clear corneal entry over the flap. This is the single dual side hard cataract phaco, and you can after this okay, thank you very much.
Dr. Tanmay Gupta for his talk on obstacles in refractive cataract surgeries.
Hello. Good afternoon, everyone. I'll be quick. So I'll be talking about the routine obstacles that we face in performing a refractive cataract surgery, which is the need of the hour. Yeah, the slide is not moving. So with the help of sophisticated equipment and technologies, and technologies that encompass our newer understandings of ocular anatomy, physiology, and pathology, desired refractive outcomes look achievable. The key to overcoming the obstacles in a summary is counseling. So the challenges that we routinely face, like IOL power calculation, can be managed by a staged approach, which can improve the patient's quantity and quality of vision. So choosing the correct IOL formula is the first challenge, primary challenge. So the Barrett Universal 2 has given us good results with 81% achieving intended refractive result. It takes into estimated lens position into account. Barrett's True K for calculates a modified K in previous refractive surgery patients. Hagees or Hoffer Q for eggshell length less than 22. SRKT for eggshell length more than 26. And online calculators should be used along with the optical biometers or A scans immersions for a better predictability. Matching IOL with spherical aberration profile. So Dr. Uday Devgan gave a decision tree, which was introduced in the American Society of Cataract Refractive Surgery conference. So in case of a patient who has undergone a prior hyperopic LASIK, a traditional IOL with a positive spherical aberration should be implanted. In cases of patients with prior myopic LASIK, aspherical IOL with negative spherical aberration should be implanted. In patients with no prior refractive surgery history, with a likelihood of IOL decentration, aspheric IOL is zero spherical aberration, and where the IOL is not likely to decenter, and if the depth of focus is critical, aspheric IOL is zero, neutral, and if the image quality is critical to the patient, like active males or active females who are driving regularly, aspheric IOLs with a negative spherical aberration. So deciding on the toricity or the non-toricity of the IOL, if the delta TK is 0.75 to 1, it suggests the toric IOL implantation. In case of any ambiguity that you face on a day-to-day practice, Barrett's online toric calculator, along with the consideration of the incision site and the SIA, gives near accurate prediction of toricity. If using a presbyopic or an accommodative IOL, even a 0.5 diopter of astigmatism should be considered for a toric IOL. Eligibility of a presbyopic correcting IOL. An ideal candidate is someone who has a low hyperopia of 1 to 3 diopters, no ocular or macular disease, less than 0.75 diopter of astigmatism, and target refraction that is within the range of correction of the chosen IOL. When to avoid previous refractive surgeries, patients with previous refractive surgery, patients who are frequent night drivers because they complain of dysphotopsias, halos, tear film deficiency, corneal disease, and macular diseases. Coming to the second challenges, that is corneal irregularities. To contain the corneal irregularity for a good emmetropia, the concept of total corneal power comes here. So most IOL calculations rely on surface keratometry measurements. In an eye with an irregular cornea, the posterior corneal surface may not exhibit the classic -6 diopter. So using the central 4.5 millimeter of total corneal power as measured by Scheimpflug or TK cone by optical biometers has resulted in good outcomes. If decentralized ectasia is seen, then corneal collagen cross-linking using the Athens protocol, which is topo-guided PRK plus C3R, can be done. Prior refractive surgery, detailed corneal imaging is required to identify prior refractive surgery ablation profile, the treatment patterns, the high order aberration profile, for identification of corneal curvature irregularities that may preclude the use of certain IOLs, to assess for the further laser vision correction candidacy, if necessary, to achieve the planned refractive target postoperatively. Surgical precisions that can be altered, that should be altered, like scleral tunnel approach in prior RKIs, knowing your SIA, the site and depth of the incision, MICS phaco, and the best will be a femtolaser assisted cataract surgery with limb relaxing incisions. Patient expectations. So cataract and questionnaire by Dr. Dell gives us an insight to the patient expectations. It helps select the right IOL for the right patient. Don't oversell the IOL. You're not the IOL manufacturer. Explain both pros and cons and explain the possibility of a refractive surprise. The myopic eyes comes with their own set of problems like the greater risk of cataract, long-term stability issues due to greater decentration issues, and multifocals are not really indicated because it decreases contrast sensitivity. So the solution is accurate biometrics, Barrett-Truque formula with central 4 mm zone in prior refractive surgery patients, plate haptic IOs are much preferred in high myopic patients, and monofocals or EDOFs. The limitations of the biometry can be seen in dense media, post-glaucoma surgery, anisometropia, amblyopia, poor fixation, and very short or long eyes. So ocular surface disease is an underestimated problem. Adequate diagnosis and preparation of the ocular surface before biometric measurements can reduce the rate of refractive surprises after surgery. Treatment is expected to primarily reduce inflammation, stabilize the tear film, and alleviate symptoms prior to the ophthalmic surgery. Thank you.
We have finished well within our time limits. Any questions from the audience for any of the speakers? Welcome. So thank you very much. I request all the speakers to kindly come for a group photograph. सक्सेना सर